My name is Cathy Obermiller, and I am a PTA at Select Physical Therapy. I've been a PTA for 23 years, and I've been doing lymphedema. Has been my specialty since 2002. I treat all kinds of lymphedema patients. It can be in any extremities. You actually can have lymphedema anywhere in the body. You have facial, extremities, truncal, genital. Pretty much anywhere you have lymphatics, you can have a problem. So I see a lot of geriatric patients. That seems to be, as we get older, with circulation issues and a lot of the other things that go on, they seem to be a little higher percentage of the lymphedema population. So this is an important thing to know and to kind of understand. Early intervention is key with the whole thing. It's important to kind of understand a little bit about the anatomy and physiology of the lymphatic system, so we can understand a little better about what's going on and when swelling occurs. You know, is it edema? Is it lymphedema? You know, there's a lot of different factors that can play into that as to what you need to do for the patient. The lymphatic system is a one-way system. It works very, very closely with our circulatory system. It starts blindly in the interstitium. We are covered from the top of our head to the tips of our toes with the superficial lymphatic system. So we have little finger-like projections that sweep that interstitial space, that pick up all of the lymph loads. It drains the cyst substances from the blood system. You know, your circulatory system or your venous system puts out a lot of the proteins and things to feed the tissues, and then anything that is too large to go back into the capillaries, the lymphatics are to pick that up. So, and it does not, so it picks up what the blood system can't drain. Lymph fluid is known, or the lymph load, or the fluid as it's known, was coined by Dr. Felde from Germany. It primarily is large molecule proteins is what makes up about 80% of the lymph load. There's about a 10% component of water and about 10% component of extracellular fragments or other cells. It basically is your body's garbage disposal in a way. It also picks up a lymph load of long-chain fatty acids that it picks up only through the digestive system. The lymph loads through the extremities and most of the trunk only contains the proteins, the water, and the cellular fragments. It only contains that fat when it comes from the digestive system. Early anatomy, it's been known since Hippocrates and Aristotle, way back when. They did identify a colorless or a milky white blood in the system. Unfortunately, it's fairly forgotten through the centuries, and it's a very overlooked system. Marie Sappi began doing, in the 1800s, did mercury injections to depict the lymphatics. And Thomas Bartholin kind of gave it its name of the lymphatic system, the vasa lymphatica. Unfortunately, it is a very underdiagnosed, misdiagnosed, undertreated condition that if it's progressive disorder, so if it's left untreated, it can have fatal effects in the complications that occur with untreated lymphedema. So it's important to be able to identify what it is. The little finger-like projections that sweep that interstitial space is the beginning or the start of the lymphatic system. Each of those little finger-like projections is covered as like a single layer of cells that overlap. So it gives us, this is the opening and closing of the system, how it pulls fluid in. Tissue pressures are very important with lymphedema in that as the pressure increases from the increased lymph load from the interstitial space, it pushes in some of those flaps to allow that extra fluid to go into that initial lymph capillary. Once it goes into the lymph capillary, then it goes into a larger, it's kind of a cross section so you can see a little better how the flaps overlap and work. It also has little anchoring filaments that attach to each of those flaps and then attach to the underside of the skin, basically, in the interstitial space. So as pressures change, as the tension of the skin against the muscle pumps, all of those pull on those anchoring filaments and help open and close those flaps to help that system move. Once it goes into the initial lymph capillary, it goes into larger lymph vessels. These are called lymphangions. They almost look like, if you threw on top so you can look, and it almost looks like a chain of pearls. Each lymphangion looks like a little ball that's connected to another ball. The lining of that lymphangion is made up of smooth muscle. So it needs a stimulus to contract to help move that fluid. So once the stimulus is the tissue pressures, compression, that's why compression is a key component to help move that along. And it's a one-way system. Once it goes in, it closes the flaps behind it so it doesn't go both ways. It will only go in one direction. So when something kind of stagnates, then everything stays still and nothing moves and everything behind it backs up. There. So once it goes through the interstitial space into the initial lymph capillary, then it goes into the larger lymph system, and then it goes into the lymph nodes themselves. The lymph node has different effects. It filters and also has lymphocytes. So, like when you get sick, the lymph nodes swell. That's how we kind of see what it does. So the lymph nodes are the initial filter, I guess. Once it goes into the lymph system, that's the main station that it's going to go to. It's a big part of your immune system. It also helps in thickening that lymph fluid to help it flow a little easier. To understand how your body controls all this fluid, so it's going in all over your body. So how does your body control that? What keeps fluid or edema from your legs from spreading into your trunk or spreading into your arms or spreading into your face? That's always a big concern with patients. Our body is separated into quadrants by a watershed. We have a sagittal watershed that cuts us right down the center, that separates us into a right half and a left half. And we have a lower horizontal watershed. It's right around the navel to about the bottom rib. So it separates our trunk effectively into 4 quadrants. We also have an upper horizontal. It follows kind of along the clavicle or the collarbone and separates our face and neck. Each of these quadrants has a cluster of lymph nodes that all of the lymph fluid from that quadrant drain to. So all of the fluid from the tips of your toes, from your lower stomach, the genitals, the buttocks, the hips, everything drains into the inguinal nodes on that side. Everything from the tips of your fingers, from shoulder, trunk, breast, upper back, all drains into the axillary lymph nodes. Everything from the side of the face to the neck all drain into the cervical chains. So this is how your body controls all of the fluid from those quadrants. When something happens to that lymphatic system in that quadrant, your body contains the problem in that quadrant. So that watershed fluid will not flow across that watershed, except through some exceptions. Both lower extremities, which in geriatrics, we get a lot of lower extremity bilateral, usually, lymphedema from, typically it's a secondary lymphedema from chronic venous insufficiency, usually. We do see a lot of lymphedema in the upper extremities from breast cancer. Is the most common thing that people think of lymphedema. And usually prostate cancer, then you'll see a lot of the males, and then a lot of the ovarian, cervical, uterine. Anytime they do anything around those regional lymph node chains, you end up with problems. So all of the fluid from both lower extremities comes together in an area behind the navel called the cisterna chyli. And at that point, that's where the lymph fluid joins with the lymph fluid from the digestive tract. gathers in the cisterna chyli, comes up through the thoracic duct, just anterior to the spine, comes up and drains into the left venous angle, which is up at this juncture. This is called we call the terminus. This is the end of the lymphatic system. So the beginning is those initial lymph capillaries in the interstitial space, and the end is up here in the terminus. So both lower extremities, left upper quadrant, left side of the face and neck, all drain to the left terminus. Right upper quadrant, right face and neck, all drain to the right terminus. So the left gets a little more work just because it all comes together from the bottom through the thoracic duct. So when we do a lymphatic treatment, people will come in with swollen legs, but I work a lot on the trunk. They're like, why are you working on my neck when my feet are swollen? We have to clear proximally to allow room for fluid to move up. So you have to work proximally in order to get that fluid from the distal regions to be able to have room to have somewhere to go. Again, one of the more common things we think about is the post-mastectomy patients when they go in, and even if they don't remove that many lymph nodes, and surgeons now are getting better at only going after that sentinel node and maybe one or two, so they're not sweeping through and taking 25 lymph nodes anymore, but they're still doing a lot of radiation. So even if those lymph nodes are still intact when they radiate them, it does create a lot of scar tissue in those lymph nodes, and it cannot function as properly as it should. So again, it's all going to drain from the upper extremity into those regional lymph nodes in the axillary region and lower extremity. The regional lymph nodes are contained within that we call the femoral triangle. And when we treat a patient, geriatrics is a little more difficult in that their memory is not so good sometimes. It's more difficult. They're not as flexible, not as mobile. And so teaching them the self-manual drainage is a little more difficult because we have to modify quite a bit and able to let them do that long term. Again, lymphedema is a progressively worsening condition if left. It's not curable, but it is treatable. Now, to understand that, when does edema become lymphedema? Now, with some, you know if you've had radiation and you have swelling on the one leg, it's pretty obvious it's lymphedema. But typically with geriatrics, that's not the case. It's usually with the bilateral lower extremities, they have swelling, the swelling comes and goes. Sometimes it stays, sometimes they get up in the morning and all the swelling is gone. Typically indicative of chronic venous insufficiency. But over time, or something happens, they get sick, they get an infection, and that swelling no longer fluctuates and the swelling stays. Well, at that point, we've probably gone into the realm of lymphedema, not just edema. Chronic edema over time becomes lymphedema. The transport capacity of the lymphatic system is where you have the amount of lymph load. The transport capacity is the amount of fluid that your body can accommodate. So when we have surgery, we have swelling initially, and then our lymphatics kick in. It'll increase the lymphangiomotoricity, or the rate of contractions of those lymphangions will increase to accommodate for the extra fluid that's being brought into the system. So it's that amount that it can normally carry of that lymph load. We have a functional reserve, and that's that amount when we have a normal amount of lymph load, where your average, what your body puts out in the fluids that your body's able to take back in. The transport capacity then is the above and beyond that lymph load that it can take, and that's our functional reserve. What happens is in a dynamic insufficiency, say with chronic venous insufficiency or right after a surgery, some kind of trauma, something that happens along those lines, the lymph load of the body dramatically increases and you have swelling. Okay. The transport capacity, your body can only carry this amount. Okay. So what happens is it backs up into that interstitial space and you have swelling. Okay. Now, a dynamic insufficiency in a healthy functioning lymphatic system, the body will accommodate for that over time, and eventually will work on that and get the swelling to go away. In lymphedema, when we go from a dynamic insufficiency into a mechanical insufficiency, this is where the lymphatic system breaks down. Okay? This is where the transport capacity drops below, because mechanically it's broken down. It cannot function the way it normally should. And so the transport capacity actually goes lower than what our normal lymph load even is going to be. So even if someone doesn't have any more surgery, you know, you just have a normal amount of lymph fluid being pumped into the system, your lymphatics cannot pick that fluid up because it's broken down. So, and again, radiation is a big cause of this, the surgery, and trauma. Causes of lymphedema, primary lymphedema in geriatrics, you won't see probably real common. What you see in geriatrics is the secondary lymphedema. This is the post-mastectomy patients, all of the cancer patients, the venous insufficiencies, those kinds of things. Stages, we typically have what we consider 4 stages. Stage 0, which is the latency stage. You don't have lymphedema, but you're at risk for lymphedema. You've had mastectomy, you've had radiation, you have a chronic venous insufficiency. You're supposed to be wearing those stockings, but you don't. Okay, you're at risk for developing. Right now, you have a you haven't gone into a mechanical dysfunction. Your body still can kind of accommodate for it, but not quite. Stage 1 is where we've gone into that mechanical insufficiency, where the system is starting to break down. Okay. This is where we have a lot of pitting edema at first, when you can squeeze the legs and you have that pitting edema and eventually comes back. If that edema stays there over a long period of time, you go into a stage 2, and this is called irreversible lymphedema. Irreversible lymphedema is that real brawny edema, or the spongy, where it looks like you could put your hand on there and it would leave your full handprint, but you touch it and you squeeze it and it bounces right back. That is a problem. That's a more advanced stage of that lymphedema, to where it's not going to be so easy. We've lost that skin elasticity, which in geriatrics is a big problem, because the older we get, our elasticity gets less and less with the skin, so we can't. That's why a lot of the swelling occurs. Your skin can't hold that in. So that's where the compression stockings and things are going to come into play. Again, lymphedema is not curable. Once you've gone into this stage 2, there's no turning back. They will always have to wear compression. They will always have to manage that edema by what we call complete decongestive therapy, or different components, which we'll get into in just a moment. So again, it can be brought back down to a normal size, but then we have to still manage that, because once you have that tendency to swell, you will always have that tendency to swell. Okay? It's progressive. Stage 3, this is where lymphedema can become very dangerous. We have incidences of infections dramatically increase. Skin changes. We have the papillomas, or the little warty skin outgrowths. You get a lot of lymph cysts that break open, which makes them more prone to the infections. Stage 3 lymphedema patients can still be helped significantly, but it takes a lot of work and a lot of time and a lot of commitment. I mean, after this patient had treatment for over 2 years, they consistently wore that compression and was able to take that down into a more normal state. Okay? So what do I do as a therapist to treat these people is called complete decongestive therapy. There's 4 main components to this. Not one is successful. If you only do one, you will not be successful in managing and controlling that edema that goes on. First and foremost is the manual lymphatic drainage. That's the massage that people think about when they do it. It's not a typical massage in that it's not a deep kneading. Remember, those initial lymph capillaries are just under the surface of the skin, less than 1 millimeter. So if we add a lot of pressure, or we dig to try to move that fluid, we actually collapse those lymph vessels and we close it off. Our purpose with manual lymphatic drainage is to stimulate the lymphatic system. We're manipulating the system to work properly because it's not doing it on its own. So all we're after when we do a manual lymphatic drainage is a skin stretch. That's all we want. We want just enough pressure to where our hands just barely grip that skin to stretch that skin. When we stretch the skin, we pull those anchoring filaments that are attached to those flaps that are on those initial lymph capillaries, and we help manipulate that system to help move it through into the lymphangiomes. Once we get it into the system, then our body can help pick it up and take it where it needs to go. It's also important to remember those quadrants and how that fluid drains. Initial lymph capillaries, the pattern of flow of the lymph fluid is it initiates or starts at those watersheds and drains toward those regional clusters of lymph nodes. That's important to know when we do manual lymphatic drainage because it gives us an idea of how the direction of the lymph vessels that are just under the surface of the skin. I can't see them, they're under there, but I have to know which direction they flow so I know which direction I'm going to stretch that skin. Okay? So once we manipulate that fluid with the manual drainage, we want to put compression on. Compression does different things. Okay? Compression increases the external tissue pressure, okay? Especially when we've lost that skin elasticity with age. It gives just enough pressure so that, again, as your muscles, as you move and the muscles pump, we are encouraging those anchoring filaments to pull those flaps, and it allows that counteract, I guess you could say, to help that fluid move into the initial lymph capillaries. Okay. It also prevents, after we've done the manual lymph drainage, it prevents or maintains the size of the limb so that it prevents a reaccumulation of fluid that you've just moved out. Because again, this is a progressive disorder. The lymph nodes in the system doesn't magically fix itself. We always have to provide these things to help it function more normally. So the compression prevents that reaccumulation of fluid. So as we move it out, we're keeping it from filling back up. Now we do this in two phases. In the initial phase, when someone comes in and they have very swollen legs, we have to get those legs down to a more normal size and then fit them in compression stockings. Stockings maintain what you have, or prevents accumulation of fluid. So the mistake that's made is people will be measured and put into stockings while their legs are swollen. And they're like, they hurt, they don't feel good, they're not working, they're not doing what they're supposed to do. Well, they're not working because they're not meant to, when you put them on very swollen, tight skin, that's uncomfortable. And so they don't wear them, they're non-compliant. And so it continues to accumulate more fluid, so then ever so often they say, I have a doctor's appointment next week, I need to put those stockings back on. And so they try to get them on, you end up with skin tears because as they age, the skin, the shearing of the stockings, it creates a lot of other problems. So phase one is we have to reduce the size of the limbs or wherever that swelling is. That's the important part. We do that by special bandages that are specially designed for lymphedema. They're called short stretch bandages. They have a high working phase when you're moving and your muscles are pumping and working. The bandages are working and compressing and moving. When you're at rest, it has a low resting phase. They just are maintaining. They don't continue to squeeze. Now, stockings have a high working phase. When a patient is up and moving around, those stockings are continuing to add that counter pressure. But they also have a high resting phase. This is why you cannot sleep in compression stockings. A lot of times, especially with our older patients, we have a problem with once they get them on, it's difficult for them. It may take them a half an hour to get them on. They don't want to take them back off that night because they have to put them back on in the morning. So they'll leave them on. The problem with that is with the high resting phases, they continue to squeeze. and you end up with a lot of circulatory issues, and you can end up with blood clots from that. So we have to encourage people to realize and understand that stockings are to be worn during the day only, not while you're sleeping. But the short stretch bandages we use in therapy can be worn 24 hours a day. When we do get patients, especially the older patients, compression stockings are very difficult to get on. Very difficult. And this is where we have a problem with compliance in that long-term management. We'll get the legs down nice or the arm down, but then they can't get the compression on that they need to be able to wear for long-term management. So what do we do? Well, fortunately, and then within the last 10 years probably only, there has been a lot of advancements in giving us alternatives to the typical stockings that you think of when you go to the drugstore and they come back with the compression stockings. We have things called reed sleeves and juxtafits. They're Velcro straps that have some tension on them. So we measure the patient for them. It's made specifically for that patient. We mark where the straps go. We have little measuring devices that tell us the pressure of the straps. So when we have someone who cannot get those tight compression stockings on, then we need to look at alternatives, because there are a lot of things out there now that a lot of the geriatrics can do, because it's difficult with their hands to be able to grip and grasp those stockings to be able to get them on. Also with the Velcro straps, we still have some problems where they can't reach their feet. So we have to modify some of the things that we do to enable them to slip it on like a boot and then be able to pull the straps. So there's some different alternatives that we can do now that we did not have available to us just a few years ago. So again, the compression is going to compensate for where we've lost that skin elasticity over time. And it prevents that reaccumulation of fluid that we've moved out. Okay. So when you have an extremity that is this swollen, when you move all that fluid out, that skin has been stretched way out, so it looks like a deflated balloon. Well, that elasticity, some of it will kind of sponge back, but mostly it's not. It really makes a big difference with people. The third components, we've had the manual lymph drainage, the compression. The third main component of the complete decongestive therapy is the decongestive exercises. Again, this is an integral part of our long-term management. It's muscle pumping exercises, because again, with the lymphatic system, it depends on the exercises are designed, they're not difficult. We try to keep it as simple and easy as possible. If you make it too complicated, they won't do it, or they're too busy, or they don't have time, or they don't remember. So we give them usually about 4 or 5 very, very basic, simple exercises. Again, keep it simple. We need that muscle pump against the pressure of that compression to be able to move that fluid and stimulate those initial lymphatics. Fourth component is good skin care. Again, bacterial fungal growth, infections is a big, big problem with lymphedematous limbs especially. We have a low immune system when our bodies are fighting all that fluid and the different infections are trying to get in there. With lymphedema, a lot of people say, well, why am I more prone to infections when I have a lot of swelling in my legs? Why am I more, prone to that? We have what we call an increased diffusion distance. When you have a lot of that edema that's accumulated in that interstitial space, we've created more space that the local defense response, when you get bacteria that enters into the tissues, our body will initially throw out the macrophages, and they get control of that as quickly as possible. When we have a lot of edema, that distance is increased, and it's filled with a high protein content. Well, that's like a big bacteria buffet. Bacteria multiplies very rapidly in that environment, and our body is slower to respond because it has more space to go through to get to that bacteria. So that bacteria takes over much more rapidly. So it's more difficult to respond to. So a lot of times lymphedema patients, they'll go to bed and feel perfectly fine. They'll wake up at 3 in the morning with a raging fever and very, very ill and end up in the hospital on IVs for the next 2 weeks. So it can occur very, very quickly. And again, our primary goal with a lot of times, especially with the elderly, the toenails and the skin on the feet, because they can't reach it, they don't take very good care of it. And so we have a lot of the deep heel cracks. The toenails are usually in terrible shape, or they'll try to cut them themselves and they cut their own toes. It's, you know, it's a lot of problems. So it's a lot of education on why you don't cut your own toenails and why you need to keep moisturizer on your legs and on your feet or arms or wherever. It's very, very important. We usually recommend the Eucerin lotion or Aquaphor, especially Aquaphor ointment on the feet, because it is a pretty thick ointment, but it does work pretty well. It's not full of the, we just try to avoid fragrances and a lot of the different additives in the lotions. You don't really want all that extra stuff because all that soaks into your skin and becomes a lymph node, okay? So we have to be careful what we put on because it's all going to become part of the problem that you're trying to solve. Again, the 2 phases, phase 1, that's our intensive phase or the reduction phase. This becomes a problem with a lot of our elderly patients in that lymphedema treatments most effectively are done daily. I see my patients on a daily basis. This is different than most physical therapy treatments, which is only 2, maybe 3 times a week at the most, but lymphedema must be done daily to be effective. It is not effective if I see a patient on Monday and they don't come back till Thursday or Friday. I will not be very effective in reducing that edema. It has to be a progressively decreasing thing. Every time that patient stays in that compression during phase 1, 24 hours a day. The only time they should be out of their compression, those bandages that I put on them, are going to be when they're in my room or they're in the shower. Okay. But otherwise, those bandages stay on. Okay. Phase 2, now this is where we've reduced that limb down to a more normal size. And my job, once I've reduced it, is to teach the patient and the family how to manage it long term, because you can't keep coming to therapy. Insurance usually doesn't allow that, and can't go home with them. So my job is to teach them everything I can to be able to manage that long term on their own. And this is where the alternatives to bandaging comes in, when they can't pull up those stockings or the sleeves themselves. You know, lots of alternatives. We try to look at a lot of different ways to be able to help them manage it on their own. Patients typically, this is the part they don't like, because the bandaging that I do with the short stretch bandages, it's a layered system. It's called, I use Comprelon. There's several different kinds that you can use. Comprelon is my favorite that I like. It comes in different sizes from 4 centimeter, 6 centimeter, 8, 10, up to 12 centimeters, and it's layered. You start with the smallest and you progressively layer all of the things all the way up the limb. Now, on lower extremities, I progressively wrap patients. The thing we have to be careful with is, especially in geriatrics, you have a lot of comorbidities that we're looking at. If we have a lot of edema in those legs, and I wrap those legs all the way up, all in one session, say they're bilaterals, I'm pushing a lot of fluid. Remember that all of that fluid from the lower extremities comes up and drains into the circulatory system directly, goes right into the heart. If I move too much fluid at once, you can wreak havoc. You can throw that patient into congestive heart failure. You can kill somebody if you do it incorrectly. So you have to be very careful. With lower extremities especially, we move a massive amount of fluid in a short period of time. So you have to progressively wrap a lot of times. We will start with just wrapping one leg. Even though they're bilaterals, I will pick one leg and I only wrap it to the knee for a day or 2. Then I will progressively wrap up the thigh, and then I will add to the knee on the other leg and then up the thigh. So every patient is different. We modify what we do to each individual patient that comes in the room because no two people are exactly alike and no two people's symptoms are exactly alike. So
what kind of symptoms would they have? A shortness of breath? I mean,
shortness
can you
of
tell
breath,
before they get to that point?
A lot, yeah. Shortness of breath. Before they leave, they're instructed if you feel pain, throbbing, the shortness of breath, chest pain, tightness, any of those things, then remove those bandages because too much fluid, their body may not be able to accommodate for that fluid that's going into that circulatory system. So, pain, lymphedema in and of itself is not painful. It looks like it would be painful, but typically your patients will tell you it doesn't hurt. It looks like it should hurt, but it doesn't hurt. Now they feel achiness, they feel the discomfort from the stretching of the skin. If they have wounds, they'll have pain from that. But if they're having a lot of pain, that pain's coming from something else, and you need to look into that to find out where that pain's coming from. But lymphedema in and of itself is not painful. Uncomfortable, but not painful. There is a difference. When we layer these bandages, we put the stockinette, we add a layer of cotton, and then we add those layers of bandages. So it's very bulky. This is a problem for our geriatric population because it, especially in lower extremities, throws your balance off. They can't wear the shoes they normally wear. So we have to modify and be careful. I may not wrap the foot quite as thick as I would like to because I'm worried about their balance. So we have to really pay attention to those balance issues and strength issues. You're also adding several pounds of supplies on their leg. That throws them off. When they're pretty weak to begin with and you add a couple pounds to that leg, it's throwing everything off in that respect also. They fatigue a little more quickly, so they don't move as much as you want them to, and you're encouraging them, you have to walk, you need to walk, you've got to move because we want that muscle pumping action and all those things working together. So we have to modify again to each individual person that comes in. So when you put them into the compression, they're happy little clams because they're used to all this bulky bandaging on their limbs, and all of a sudden now it's sleek and slim. So if they can get it on, it works pretty well. So they're a little more compliant with it. And again, you can compress any part of the body with compression. Okay, so if they have a lot of edema in the hips, we have the full panty compression. We have for the chest vests, we have facial masks, we have every kind of compression. We can compress anything externally from the body. It may not be comfortable, but we can do it. We also have different phases of compression. Now in lymphedema, this is where it becomes a little tricky with our geriatric patients because typically, a lot of people think of the compression stockings they think of the TED hose that they're given when they have surgery. And, the TED hose are, 10, 12 millimeters mercury of pressure, which is all you need for venous return when you're lying flat in bed. The instant your legs hit that floor, you need a minimum of 30 millimeters mercury to help with the good venous return. So, but most geriatric patients, they're not going to be able to get stockings that are 30 to 40 millimeters mercury of pressure on. They're a little stout. But they may not need quite that much compression for that return that you need. So a lot of times we will go down to the 20 to 30. I don't like going less than that because it really is not very effective. You can even go, if they can get one of the TED hose style on, we've even gone to where we'll layer 2 of those on. That's not ideal. It's not what I would want to do, but sometimes that's our only choice. We also have problems with that shearing of the skin. When they try to put on those higher compressive stockings, they get a lot of skin tears, so we have to be careful with that. So the compression in phase 2, this is always a tricky thing to come up with what's going to be appropriate. Now, what I see coming in to see me a lot of times is this, where they've been improperly fitted with the compression stockings. And I would rather them not have compression on at all than have an improperly fit compression stocking or arm sleeve, because you can create more problems and do more damage with an improperly fitted compressive garment than with nothing at all. Okay. So again, our goals is to decongest, identify what stage they're in so we know long-term management, what it is we have to set them up to do. We want to maintain that reduction long-term, and that's the hard part, is how do we maintain that, especially with our geriatric patients, because they typically are some of the more non-compliant because they don't feel well, they don't feel like putting their stocking on or their sleeve that day, so they don't. So then it gets a little more swollen where they haven't worn the compression and they've gone back into that old cycle. I get a lot of what we call repeat offenders that come back fairly frequently because they don't follow through with what they've accomplished by coming to therapy. We want to prevent and eliminate infections. Again, this is key because this is where it becomes life-threatening. Those infections, especially in your geriatric patients, it can be very dangerous for them. Puts them in the hospital for a long time. And reducing that fibrotic tissue. The fibrotic tissue develops in those with that high protein content in that interstitial space. The longer that extra fluid stays there, the thicker that becomes. And when it becomes thicker, it traps more of that fluid within those spaces, and that's where you get that progressive condition. Now again, this is just kind of showing the patterns. We follow patterns. Depending on where that fluid is, we follow patterns and go. Now the problem we have with a lot of geriatric patients is they have had multiple issues throughout their lifetime. So ideally, I'm going to move this from the affected quadrant into these adjacent unaffected quadrants. In geriatrics, though, we typically don't have that many adjacent unaffected quadrants. There's always something else that's gone wrong in that other quadrant where you don't want to overwhelm that quadrant with extra fluid because you might throw that quadrant into lymphedema. So you have to be very careful and try to really get a good history on these people because that's going to be key. And it never fails, so come back and go, oh yeah, I had, you know, cancer, colon cancer, and had radiation 20 years ago. Well, you know, that might have been important for me to know because I'm now, because they're having swelling starting in their leg that I'm moving fluid into, and I don't know why. So those are important things to know. And again, it's not just extremities. We mostly think of it as the legs or the arms, but it can affect different parts of the body. The trunk, because again, those watersheds, everything from the trunk flows in, and a lot of people will have fluid in the trunk and not even really realize it. You know, they'll feel like there's a lump under their arm when they put their arm down, but it becomes normal feeling to them so they don't realize it anymore. It can happen, it goes into the genital areas. The problem with lymphedema in the lower extremities is the old way to do that was they would put them in pumps, the old style pumps. Not a good thing to do. The pumps work distally to proximally instead of proximal to distal. So it's trying to push fluid and squeeze fluid using too much pressure. It can't get out of that quadrant, so it goes into the next area of least resistance, which unfortunately is the genital area. About 60%, in studies that have been done, about 60% of patients that were put into the old style lymphedema pumps for lower extremities developed genital lymphedema within a year. So we do not recommend those old style pumps for the lower extremities anymore. There's very few pumps that we would put somebody in. This is called FlexiTouch. It's a fairly new device. It's only come out within the last probably 6 years, I guess. It's only become more prevalent within the last couple of years. It's not an alternative to complete decongestive therapy. Education is a huge part of managing this. So you don't want to use this in phase 1, that reduction phase. But this is a tool to use for long-term management, especially for geriatrics who can't maybe do the compression as much as you would like, or they can't reach their legs because they can't bend over, they're not flexible enough. So this does the manual drainage for them in a way. It's made up of individual chambers of about 1 inch wide. No two chambers are filled at the same time, and it only goes up to about 20 millimeters of mercury of pressure. So it we're not squeezing. It simulates the manual lymphatic drainage. Okay. It was designed by a lymphedema therapist. This is something that we really hate to see come in, but we do see where plastic surgery has gotten a hold of a lymphedema patient, and their answer to getting it down is to debulk. Debulking long-term doesn't work. Whatever few lymph vessels were there that were working have now been removed. This does not cure lymphedema. You still will swell. You have more and more scar tissue. The risk of infection is astronomical. It doesn't heal. It just, it's an awful disfiguring thing that does occur, unfortunately. Pharmaceuticals, you get patients that Google lymphedema and they come in and, you know, well, I've read about these things that can help me with my lymphedema. Well, you have to be very careful. Diuretics do not work in lymphedema. The difficulty we have is, you know, they'll have swelling, they'll complain of swelling, the doctor will give them Lasix or a water pill, and it kind of works, but not really, and they go back, it's not working, so they double the dose. Well, it still doesn't go down, so they'll give you a different kind, and it still doesn't work. Well, it doesn't work because lymphedema is only a 10% component of water. It's mostly proteins. Those diuretics do not work in lymphedema. We have available to us now low-level laser. This is fairly new. Was just approved in the fall of 2009 for use in lymphedema patients. There's very few around that utilize it, but it works very, very well. So I've been pretty pleased with that. So thank you very much. I appreciate listening. Does anybody have any questions?
So somebody who has like this massive elephantiasis, horrible legs, you know, typical person who can't even reach their feet, and nobody can help them really. So if they were to come in every day for the type of manual decompressive therapy, how long would it take to get the legs down to where you can go to the next phase?
Every patient is different. I can't give you an exact time frame. Typically, it can take anywhere from about 8 weeks to 12 weeks for lower extremity. Kind of depends on patient compliance. But it can be done. It does work.
And like, does Medicare pay for this?
That's a big problem we also have with the geriatrics, because insurances is our biggest foe. We have a cap with Medicare for physical therapy. It is, I think, $1,760, I think, this year. They had a moratorium on it. That moratorium was lifted. The cap is in place for this year. Fortunately, we're getting ready to go into a new year. We have to work with that. There are what we call automatic exceptions that they allow us to go over the cap. Lymphedema is a diagnosis that is covered under the automatic exception with lots of paperwork, but it can be done. A lot of the HMOs limit us pretty much. Secure Horizons, unfortunately, we have a little issue with because they'll give me 6 visits. Well, if I have a stage 2 or stage 3, I can make some progress, but I'm not going to do what I need to do in 6 visits. I typically, with bilateral lowers, it will take anywhere from 2 to 4 weeks. Upper extremities, about 2 weeks to 4 weeks, depends on the stage, will depend on the length of treatment. Again, each individual patient that comes in is going to be different. So your swelling may come down in 2 weeks, and your swelling, it may take 4, yours might take a week. You know, sometimes it's very dramatic, and sometimes if they have a lot of fibrotic tissue, it takes a lot longer.
So how do you tell when you're looking at a patient whether it's lymphedema or it just won't pit?
The non-pitting is one of the signs. The stemmer sign is another, where you can pinch the tissue. A lot of times on a hand, if you pinch the tissue here, see where I can pull tissue up? Okay, if you have a lot of edema, or the lymph edema in there is real thick and brawny, you can't pinch up skin. And on the legs, you can try
For
to
regular
pinch
swelling,
up
you
from
wouldn't
the,
be able to either.
probably not. We usually typically do it on the hand and on the dorsum of the foot is where we look for a positive stemmer sign.
But that wouldn't tell me whether it's edema or lymphedema.
It should be lymphedema. A regular edema is, you're probably going to be able to still pull up
Oh,
some.
really? Okay.
Lymphedema is a little thicker. It's more what I call brawny. I don't know, it's real spongy-like. It doesn't, I mean, you can try to pull it up. It'll pull up some, but it'll it just kind of, you won't be able to really do that. Especially in geriatrics, so a lot of them are dehydrated, so you do this and it stays there for an hour. So, but if they have lymphedema, you won't be able to do that at all. But again, how it feels, whether I can elicit a skin stretch. Did the doctor try diuretics and it worked or it didn't work? Okay. You can still do lymphedema treatments on the chronic venous insufficiency. We do manual drainage and compression on those people. Those are the ones that are done in a week because it wasn't lymphedema, but the system breaks down still, or it's not able to accommodate that. So it gives it a little help and it really makes a big difference. So even if you don't know if it's just CVI or if it's gone into lymphedema, it will eventually become lymphedema if left untreated. So early intervention is key. We can make a huge difference the earlier that patient is sent when they have that edema and that swelling. Makes a big difference.
Thank you very much. Excellent.